So, as I said, welcome everyone to this introductory webinar of the New York Hypermobility Collective. My name is Dr. Melanie Carminati. We have Dr. Jason Siefferman joining us as well and presenting, Dr. Nino Mikaberidze, and Dr. Deborah Barbiere. All will be presenting in this evening's webinar. The agenda. So we're going to start just introducing ourselves, introducing the collective. We'll then be transitioning into EDS and HSD overview, as well as pain management interventions. Following up, we'll get into some rheumatological considerations, pain psychology for people with EDS and HSD. I'll be speaking about physical therapy and exercise considerations for people with EDS and HSD. And then all four of us presenting, all of the four individual providers, practitioners here, will be doing a collaborative case discussion. After that, we'll have some time for Q&A and just some closing remarks. So the scope of this webinar, just so everyone's expectations are clear, is that this is a brief and introductory webinar, and we're going to do an overview of the important aspects of EDS and HSD. We're going to focus mainly on evidence-based details and acknowledge some of the evolving aspects of understanding and treatment of these symptoms. We honor other diagnosis-based correlations and treatment options and look forward to presenting more on this in the future with greater depth. As a disclaimer, this webinar is informational and it does not serve as individualized medical advice. Please follow up with a specialized healthcare provider and specialized resource teams specific to your needs. I hear someone just in the background. Make sure that your camera and your mic is muted, or camera's off, mic is muted. Thank you. Okay, so the New York Hypermobility Collective. So we are a collective of healthcare professionals, and we specialize in the unique care of people with HSD and EDS. We provide high-level coordinated care, evidence-based treatments, and we focus on these multiple bodily systems that are affected by this syndrome. There's multiple practitioners that are involved in the care of EDS and HSD. This can include physiatry, rheumatology, physical therapy, neurology, orthopedics, gastroenterology, cardiology, and so much more. As some of you who are joining us today already know, these conditions, they require a collaborative team and they require many different specialized professionals to efficiently help and treat this condition. Our mission is to educate and to care comprehensively and holistically for those people with HSD and EDS and their supportive relationships. We're currently in the beginning phase of our existence, so we are continuing to seek other providers and specialists in EDS and HSD to join our collective. So if you are one of those other providers and specialists who are joining us now, joining us this evening, and you want to connect, please connect with us. We'll have our contact info after. Okay, I'm going to turn the mic over to Dr. Siefferman.
Hello, good evening. Thank you all for joining us. I'm going to start by giving a brief overview of Ehlers-Danlos Syndrome and hypermobility spectrum disorder. Just so you know a little bit about me, I'm a physiatrist with interventional pain fellowship training, and I'm also board certified in headache medicine. So looking at EDS, the first things we have to consider are the definitions. With Ehlers-Danlos syndrome, we know there are multiple types. The most common type is hypermobile EDS. Most of you may be familiar with that, also known as type 3. The important thing about hypermobile EDS is that there is no known genetic source. So if you go for genetic testing because you suspect you have EDS, don't be surprised if they tell you there's no test, genetic test anyway. There are genetic tests for other subtypes of EDS like classical or like vascular, and we'll speak about some of the differences in those because there is a lot of overlap between the subtypes of EDS. I put a link at the bottom where there's a nice PDF overview of these subtypes. If you are interested in reading more about it, that's very easily accessible. So looking at the most common types of EDS, hypermobile EDS, there's about 1 in every 3,000 to 5,000 individuals. So it is fairly common as far as conditions go. We don't know any of the genes or proteins. It does seem to be autosomal dominant inherited, meaning you only need one effective parent to get it. And the core symptoms are generalized joint hypermobility, joint instability, and chronic pain. Classic EDS has a lot of these same features. It's less common. There are genes that are known, and it can affect type 5 or type 1 collagen. The biggest difference is skin fragility. So it's much easier to fracture skin. So skin over tight areas like the foreheads or the front of the shins can crack and break easily. It's also difficult to heal after surgery, and you may also have more saggy, stretchy skin than you would with typical hypermobile EDS. And again, you can have some of these symptoms with typical hypermobile EDS and not have the genes of classical EDS. It's just a range of the spectrum. Vascular EDS is where there's vascular fragility, meaning the arteries can rupture and you can have severe life-threatening bleeding. This can occur in the aorta, in the vertebral artery, a lot of different areas. The other interesting thing about vascular EDS is that it also affects the organs, and it's very easy for the organs to rupture. You may have heard of pneumothorax, which is the lung spontaneously rupturing. And of course, this can happen with classical EDS, but it's more a hallmark of vascular EDS. And of course, you can have spontaneous spleen fractures or liver bleeding, other things like that. Looking at the EDS spectrum, this is really just looking at hypermobile EDS and all of the symptoms that go along with it. I borrowed this from the Ehlers-Danlos Society because they have a lot of great educational material on their website. So when you're looking at these core symptoms, we're thinking about joint instability, mast cell activation syndrome, which happens commonly with hypermobile EDS, pain, fatigue, GI issues, dysautonomia, headaches, and anxiety, other neuropsychiatric side effects. We'll get into that in a bit. This is a better Venn diagram sort of showing the overlap. They've got classical EDS here over on the side, vascular EDS, and then the kyphoscoliotic EDS at the bottom. So you see in the middle, there's easy bruising, joint hypermobility, and then there are some other more specific issues that happen more commonly within each subtype of EDS. How do we diagnose hypermobile EDS? Well, it's history and physical exam. So if you go see a geneticist for hypermobile EDS, they're probably going to whip out a form similar to this. They're going to check the Baton score, which is these 5 maneuvers looking for hypermobility, and then you get a score based on that. There's all of these questions that you have to go through and certain criteria that you have to meet. And this was developed by a consensus of professionals. This is not evidence-based. It's purely professional opinion. And it will probably change in 10 or 15 years or whenever this consensus group meets again. The most interesting part about this is at the bottom, which I'll get a little deeper in that in a second. When we talk about hypermobility spectrum disorder, what's the difference in hypermobile EDS and hypermobility spectrum disorder? The only difference is that you meet the consensus criteria. So they are otherwise exactly the same. And this is important because 3.2 on that form that I showed you before says exclusion of other heritable and acquired connective tissue disorders, including autoimmune rheumatologic conditions. So I don't know how many of you have or know people with hypermobile EDS, but coincidentally, there seems to be quite a high confluence of autoimmune processes. And it can be quite confusing as you dig into it because mast cell activation syndrome, which is allowed, it's not considered one of these autoimmune that would exclude you from having hypermobile EDS, but it does often present with other autoimmune-like processes and can be quite confusing. So if you do have a primary autoimmune condition like lupus, rheumatoid arthritis, psoriatic arthritis, Sjogren's, any of these things, then you actually have to go back and meet a lot more additional features to satisfy the diagnostic criteria for hypermobile EDS. And most specifically, your parents have to have it. All right, let's dig into some of the associated conditions with hypermobile EDS and hypermobility spectrum disorder, because this is often how we end up diagnosing hypermobility syndromes, because patients don't come in complaining of being hypermobile necessarily unless their shoulder is falling out. They generally come in complaining of some array of symptoms that has been misdiagnosed as fibromyalgia, or it's all in their head, or something along those lines. So we're looking at headache. People in the normal population, looking at migraine specifically, people with hypermobility, 30% have migraine, as opposed to the normal population where it's 6% of men and 18% of women. So headache is much more common with hypermobility. Neuropsychiatric side effects, so ADD, ADHD, OCD-like symptomatology, which Dr. Barbiere may speak about a bit more. Craniocervical instability, and this speaks to a whole subset of symptoms that occur when the head is not securely fastened to the neck. We know the head weighs about 25 pounds. The neck is relatively small. The ligaments responsible for holding this juncture together need to be sufficient. If they are not, the head will start to slide onto its post on the neck. And when that happens, a whole variety of other symptoms occur. You can have restriction in cerebrospinal fluid outflow from the brain. You can have compression of the jugular veins. You can have tension on the nerves that exit the brain, like the sympathetic plexus, the vagus nerve, the glossopharyngeal nerve, and these can each present with their own symptoms without any other symptoms of CCI along with it. So diagnosing CCI and looking at the bigger picture is important. There can be dental issues or TMJ dysfunction. Thoracic outlet syndrome, which is where the nerves that come out of the neck course between many muscles en route to the arm. So with thoracic outlet syndrome, there is compression of veins, arteries, and or nerves as they exit the neck and exit the thorax, which can be due to hypermobility. Dysautonomia. Dysautonomia means that your autonomic nervous system is not functioning appropriately. What does the autonomic nervous system do? It balances all of the body's automatic functions. So if you think of your pulse, your blood pressure, sweating, digestion, normal movement of the gut, even your fear and anxiety responses, your reflexes can even be modulated this way. So the dysautonomia can be affected because if there is some craniocervical instability, if there's any stress or stretch on the vagus nerve or the sympathetic chain, it will affect how all of these things function. And separately, if there is too much stretch in the ligaments that hold the bowels in place, too much stretch in the tissues of the gut, or any of the other organs for that matter, it will affect the reflexes and the dynamics between them. So what does dysautonomia present like, or how can it present? If you're familiar with POTS or positional orthostatic tachycardic syndrome, if you stand up and get dizzy, or if spontaneously you feel like the heart is just beating really fast, that can be a type of hyperadrenergic POTS. Adrenal insufficiency, which when the adrenal organs, which are responsible for producing cortisol and aldosterone, those are more commonly affected in EDS than the normal population. You can have insufficient hormone production so that you actually have more POTS from that. And you also get volume distension because gravity and stretch pulls all the blood as close to your feet as possible, and the blood vessels are stretchy so they can accommodate them. Gastroparesis means that the stomach is not moving. You need the vagus nerve for the stomach to empty. And if the sympathetic nerves are hyperactive, then the stomach will also not empty and the bowels will slow down. So this will keep the stomach from emptying. This can cause nausea. It can cause acid reflux to come back up the other direction. It can cause the small intestine bacterial overgrowth because things aren't moving along. The bacteria just build up. And of course, it can cause constipation as well. And these things can all co-occur. Usually when we think of hypermobility and EDS, we think of joint subluxations and dislocations. That's almost one of the hallmark symptoms. But you do not have to have these to have hypermobile EDS or hypermobility spectrum disorder. You can have a lot of these other things going on, and the joints might be loose, but they may not actually spontaneously sublux. You can still be more prone to sprains and injuries, of course. But subluxation of the joint, which is where the joint is sagging or there's hypermobility of the joint, dislocation where it's actually properly displaced. Anytime either of these happens, there's also injury to the surrounding structures. So if you think of the shoulder dislocating, the shoulder cannot dislocate without injuring the labrum. Same thing with the hip. Even a subluxation will often pull and tear at the labrum. And the muscles that are responsible for holding the joint in place, the rotator cuff muscles, are also overused. There's often tendinopathy, and you can even get tendon tears in the rotator cuff because those muscles are often working overtime just to try and hold the joint together because the ligaments that are supposed to be doing that job are too stretchy. Gravity compliant posture. This is the polite way of saying bad posture. If you think of typical upper body sagging, hyperextended neck, bad posture, that's generally how gravity will pull a person down if the ligaments don't sustain the forces that gravity puts on them. And this will contribute to some of these other issues like the TMJ dysfunction because head and neck positioning affects jaw function. It will play into thoracic outlet. It will play into blood flow going back into the brain. There's a lot of trickle-down effects from this. Organ prolapse. So this is where we think about bladder, rectocele, even stomach with hiatal hernias. This can happen in a lot of different locations. Don't always know that they happen until we take a look. Sometimes we find it just by accident. Other times patients come in with that specific complaint and we have to question why this is happening, and that leads us back to a diagnosis of EDS. Vascular occlusions. Vascular occlusions will happen for a couple of different reasons. One reason, especially with venous occlusion, it's just that the veins do not have enough intrinsic strength to stay open and they will collapse. They'll just spontaneously collapse. If there's enough blood flow, yes, they can open back up, but sometimes it takes a good amount of blood flow, and sometimes the resistance downstream from that blood flow is so low because the blood vessels are so compliant that the blood pressure doesn't really build up to allow the vein to open up so that blood can return. So it just pools and stays distal to the heart. This happens more with pelvic congestion syndrome in the iliacs in the lower part of the body. In the upper part of the body, the jugular vein can be compressed because it's stretched or tented over the C1 transverse process or a styloid process, or it can just spontaneously happen there as well. MALS and SMAS, median arcuate ligament syndrome and superior mesenteric artery syndrome, are two specific diagnoses that happen more often in hypermobility. And in this situation, it's blood flow affecting the gut. And because they're sagging and stretching of the ligaments that hold things in place, the arteries can become occluded. With arterial occlusion, you actually lose blood flow and oxygen to an area, which causes substantial pain. Typically, it causes abdominal pain and nausea. And nausea might even be the prevailing symptoms of this. And then, of course, pelvic congestion syndrome, which is where blood just pools in the pelvis. And May-Thurner is when there's a valve disorder and that causes pelvic congestion. Pelvic pain dysfunction, we know about that. We mentioned mast cell activation syndrome. There's a number of autoimmune conditions that seem to be more prevalent in hypermobility syndromes, and then poor healing. Other considerations, there's a lot of other conditions that present with things that seem like hypermobility or have hypermobility or share a lot of the same symptoms. So we don't just jump to this diagnosis, even though it is very common. We want to make sure there's not something more ominous in play. And what is our clinical approach? Generally, we want to identify the primary conditions. Is there hypermobility? Is there craniocervical instability? Is there migraine? Because if there's migraine, it's going to sensitize everything. Is there PTSD? Because this plays into the sympathetic pathways, and dysautonomia and PTSD follow the same pathways. Are there other specific injuries or primary pain sources, like endometriosis? Anything else that's going to cause pain or sensitize the nervous system, we need to identify, we need to know about. If there's any structural instability, if there was a sprain or a prior injury or a fracture or anything that's affecting the mechanics that's not hypermobility or that may have been worse because of hypermobility, we want to understand all of that and put it all in context together. Then we want to look for secondary conditions. And this is important because it's often the secondary condition that brings the patient in. They may come in with myofascial pain or dystonia, which is involuntary muscle contractions. We see a lot of pelvic dystonia from pelvic floor dysfunction. They may come in with a shoulder subluxation or TMJ dysfunction or a peripheral nerve entrapment. It's important to recognize if that is not a primary process, because if we treat the secondary process without recognizing the primary processes, the patient's not going to get very far. They're just going to keep having the same issue over and over. So we want to understand the how, what, and why behind the pain that brings the patient in. Once we get an understanding of that, we discuss it. I map it out for the patient, and there's usually a cascade, one thing leading to another, that helps us understand the constellation of symptoms that are going on. And once we have that, we kind of want to choose where we start to tackle this. And it's almost like there can be layers of patina or a snowball effect of all these things that have built up over time, because it's not usually something that just happens instantly. It's usually years and years of things building up until they get to a point where it's no longer tolerable. That's when they seek care. So we want to establish priorities and goals, like what's the most important thing of all of these things going on, what causes the greatest amount of dysfunction. We want to track that back to a presumed root cause and try to treat that spot, treat that area. So when we look at treatment categories, we think of these buckets of treatments. We look at medications, and medications generally don't fix things, but they can make them better temporarily. And if we find a medication that does something, that has some effect, that gives us more information about what's going on with the body, depending on which neurotransmitters are in play or whether there's inflammation or not inflammation. If we think there might be mast cell activation, we give a mast cell drug, we see if that changes anything. It really helps us understand what's doing what. And that's important when we put together the full treatment plan. So there is a little bit of trying to understand what's going on with the body. There are physical modalities, which we think about physical therapy, which is essential for proprioceptive training, strength training, balance training, all of these things to learn to re-coordinate the muscles, recognizing the end range of the joints. We also think about chiropractics, which do have a role in hypermobility syndromes. We can talk about this later because it's quite nuanced and you really want to know what you're getting into. But there are distinct roles for chiropractors with hypermobility, acupuncture, other heating, stretching, cold laser. There's a lot of other physical modalities that people use that are worth discussing because some can be helpful, some can be harmful. We really want to question what we're doing, why we're doing it, what we're anticipating this will accomplish. And then whatever happens, we learn from that and we incorporate it into our bigger understanding of what's going on. When we get to procedures, that's where we're looking to diagnostically confirm something. And I say this because it's quite broad and it is quite vague. There are a lot of things we can test diagnostically. If we think a joint is a source of pain, we can put local anesthetic in the joint to turn pain off and then confirm if that's a source of pain or not. Just putting local anesthetic on a structure won't confirm if hypermobility is the problem. If we want to test for hypermobility, imaging is generally not great. Some situations we can, but it's not always reliable. For the hip, for example, we may just put fluid in the hip and see how much fluid is accommodated by the joint. If we can put more than a certain amount of fluid in the hip, for example, we know that there's hypermobility there because otherwise it wouldn't accommodate that amount of fluid. And then if the patient gets up and walks around and feels more stable afterwards because we've given pseudo-stability by filling the joint with fluid, that is additional confirmation that hypermobility was present and that hypermobility was contributing to dysfunction of that structure. One of my favorite locations for this specific thing is at C1, C2. So if we are diagnosing craniocervical instability and we see on imaging that C1-2 is hypermobile, I can go into the joint with a very teeny tiny needle and place fluid. And the joint is only supposed to hold 0.3 mLs of fluid. Generally, with hypermobile patients, I can put a cc and a half into the joint. That by itself proves that they're hypermobile. And then immediately afterwards, we have them sit up and see how they feel. And whatever feels better from that joint being full and distended is directly related to what the hypermobility of that joint was causing as a problem. So this is the diagnostic process for hypermobility with pain, because a joint may cause problems without itself being painful. And this is where things get really confusing. When it comes to pelvic pain, for example, it's quite common for sacroiliac joint hypermobility or hip joint hypermobility to cause pelvic floor dysfunction because all of the pelvic muscles will react to stabilize the pelvis. And there's no primary pain in the SI joint or the hip. How do we figure this out? we examine. If we feel hypermobility on exam, we put fluid in the joint. If that allows the pelvic muscles to relax, then that's proof of concept that it's just reacting to the instability of the joint. Then we proceed with regenerative medicine options, which are meant to tighten or strengthen the supporting structures of the joint, which is a longer-term solution. Now, of course, not everybody responds to every treatment, but these are what we have available. And generally, we will start with dextrose prolotherapy, where we inject sugar. The sugar chemically irritates the ligaments, which makes the collagen proliferate. It makes the ligaments become stronger, and it tightens the joint. If they do not respond to prolotherapy, we will generally escalate to platelet-rich plasma, PRP. That's where we draw your blood, we spin it down, we inject the platelets. The platelets themselves produce a healing response, which can also stimulate proliferation of the collagen and strengthen the structures. And between these two things and physical therapy, we can generally treat a hypermobile joint and make it more functional and less painful. Finally, knowing that there are neuropsychiatric side effects to hypermobility, and knowing that there's widespread effects of hypermobility and pain on someone's life, the role of pain psychology cannot be overlooked. So even if it's as simple as strategizing care, making goals, pain psychology can be very helpful. Dr. Barbiere will talk more about that. And finally, it's important to know that everyone's response is different. Everyone is individual, and as much as it would be nice to have cookie cutter medicine like we have for blood pressure or diabetes, we do not have that for pain, at least not yet. So there is a little bit of an iterative process where we try something, we see what happens, we see how the body responds, we incorporate that in our larger understanding of what's happening, we adjust our treatment plan, and we go from there. There is a little bit of trial and error to find the best course for each person. So I kind of spoke about this, so I won't go into it too much, but in general, with pain, we want to identify the problem. Like, what is the core issue? Why is it happening? How did it come to happen? What can we do to actually treat that long term? So most approaches for pain involve injection of steroid because steroids make people feel better, generally. For hypermobility, for sprains of joints, steroids usually don't help so much, and they soften connective tissue, which makes things more stretchy, and they certainly don't provide any long-term solution. On the other hand, if there's an autoimmune condition coexisting with the hypermobile condition, we may want to prove that by giving a steroid injection. And the way we'll find out is we put a small amount of steroid in the joint. If they respond, if they feel amazing, there may be something more autoimmune going on, and that's when we'll work with the rheumatologist to tease that apart. Otherwise, regenerative medicine is generally the approach for hypermobility syndromes. Sometimes we don't start with the steroid because we don't suspect an autoimmune condition, and we start with regenerative medicine, and that can flare. And if someone flares with the regenerative medicine approach, that again makes me suspicious. Is there some autoimmune inflammatory process in play, or maybe there's some mast cell in play, because that can also react to it. So like I said, everything we do, it gives us a greater understanding of what's happening with the patient. We take that, we incorporate it into the bigger picture, and we work together. It's always a process. So again, if the core issue is laxity, we want to strengthen the ligaments and the supporting structures to improve stability. If the laxity is not treated, no amount of muscle coordination and strengthening is going to compensate for that laxity, because the core issue of the laxity will catch the patient when they're not guarding, when they're sleeping, when something else is happening. Or if they're using muscles to compensate for the laxity, they'll end up overusing those muscles, and then they'll come in with pain, disuse, tendinopathy of those muscles that are being overused. So looking at laxity and how we can treat that is the main goal of procedures for hypermobility spectrum disorders. And again, diagnosing pain versus hypermobility, I spoke about that a little bit. We want to understand both. Just going over the role of interventional physiatry, which is what I do. We are the specialists in biomechanics. We're the ones who really sort of put muscle, tendon, ligament, bone, joint, nerve function all together. We generally do diagnostic ultrasound, so we can use an ultrasound in the office to look at what's happening. We can often see hypermobility in real time. I can diagnose hernias in real time. A lot of hypermobility associated conditions can be diagnosed with ultrasound. We can also guide on when bracing is appropriate. There's mixed thoughts about bracing because when you brace something, you don't use your own muscles to guard that structure, and those muscles can get weak. But there is a role for bracing, both diagnostically and therapeutically, and to prevent further injury. We can help with that. We're also the specialist in brain injury and spinal cord injury. So if there is craniocervical instability, tethered cord, autonomic dysfunction, CSF outflow, these are things we're all familiar with treating. And we also work closely with neuropsychologists, social workers, physical therapists, vocational rehab, all of the multidisciplinary team that's typically required to care for someone with more significant hypermobility spectrum disorders. And then, of course, we also do all of the procedures we talked about.
Good evening, everybody. Thank you, Melanie, for your introduction, and I'm really honored to be part of this webinar tonight. Again, our topic today is connection between hypermobility and autoimmune diseases. For those who don't know who is a rheumatologist and what we do, rheumatologist is basically internal medicine physicians with subspecialization of training in rheumatology. And this medical specialty deals with musculoskeletal conditions as well as autoimmune and inflammatory diseases in people of all ages. And many of these conditions may run in families. So Dr. Siefferman already covered different types of Ehlers-Danlos Syndrome and types. We know that there are more than 13 subtypes, but we're going to focus more on the most common form, which is a hypermobile type EDS and its variant hypermobile spectrum disorders, because they are the ones correlated with rheumatological and inflammatory conditions. In general, pain in hypermobility and HSD is multifactorial, and it may arise as a consequence of recurrent soft tissue injuries, dislocations, and nerve entrapment, and through abnormal neuropathic mechanisms of central and peripheral sensitization. Patients with joint hypermobility and hypermobility spectrum disorders were most likely to have autoimmune markers and autonomic dysfunction. Specifically, 43% of patients with joint hypermobility and HSD had autoimmune markers compared to 15% of those without, indicating association between hypermobility and autoimmune conditions. Higher prevalence of joint hypermobility in patients with systemic lupus, and we have a study showing that 40% of lupus patients exhibit hypermobility compared to 15% in a control group, suggesting a strong link between lupus and joint hypermobility. This relationship really underscores the importance of considering autoimmune evaluation in patients presenting with hypermobility and related symptoms. Common autoimmune diseases associated with hypermobility could be lupus, rheumatoid arthritis, Sjogren's, muscle activation disease, immunoglobulin deficiencies, ankylosing spondylitis, psoriatic arthritis, small fiber neuropathy, and many other more autoimmune conditions. Hypermobile EDS is associated with complicated rheumatological conditions which are uncovered by comprehensive workup. These conditions require different clinical management strategies than classic EDS without autoimmune diseases. And usually left untreated or undiscovered could contribute to the pain or even physical disability and can lead to the more injuries and more negative outcomes like joint erosions in those patients. Clinical manifestation of hypermobility and autoimmune diseases often overlap, making it difficult to distinguish between the two. And most effective diagnostic techniques for hypermobile patients with autoimmune diseases involve combination of quite detailed history, physical exam, serologic tests, and imaging modalities. And I would like to highlight few imaging modalities because these are really part of our daily routine of treating our patients and making our diagnosis. It's really an ultrasound, which is highly effective for detecting a joint and tendon inflammation, even in the absence of clinical synovitis. It is also useful for early identification of bone erosions and assessing disease activity. MRI is crucial for early diagnosis and assessment of musculoskeletal involvement. It's valuable for evaluating inflammation, such as seeing the synovitis and tenosynovitis, which is basically inflammation of joint and inflammation around the tendon, particularly when clinical and laboratory measurements are inconclusive. Conventional radiographs like X-rays remains the gold standard for evaluation of structural damage, particularly in people with RA and ankylosing spondylitis. However, its sensitivity for early changes is limited, and making it less useful for early diagnosis. CT is another great diagnostic tool. However, inability to distinguish soft tissue can happen with CT, and also there is a amount of radiation with it. So in summary, ultrasound and MRI are the most effective imaging techniques for hypermobile patients with autoimmune diseases, while autoantibody testing and biomarkers are crucial for serological diagnosis and disease activity assessment. Hypermobility can significantly impact the management of autoimmune diseases due to its association with a higher prevalence of autoimmune markers and conditions. This really necessitates a multidisciplinary approach to a treatment, considering both hypermobility and autoimmune aspect of the disease. And we know that a particular study done particularly in the pediatric patients by Black and authors demonstrated that children with juvenile idiopathic arthritis and joint hypermobility had higher disease activity and poor outcomes compared with JI alone. This really indicates that joint hypermobility can exacerbate the disease burden in autoimmune conditions, necessitating more aggressive and tailored treatment strategies. As Dr. Siefferman already talked about, physical exam and physical and occupational therapy is very important. It's a cornerstone of the treatment for hypermobile patients with autoimmune diseases. Tailored exercise program to increase core and extremity muscle strength, proprioception, joint stability are essential. Occupational therapy can assist with ergonomic adjustments and use of assistive devices to reduce strain on hypermobile joints. Sometimes braces and splints, depend on the case. Pain management, always individualized, as well as rheumatology involvement, has to be very individualized and case by case. We usually introduce pharmacology intervention such as NSAIDs, corticosteroids, and depends on the response. Most of the time, once we diagnose autoimmune diseases based on the disease conditions, we start discussing about more targeted therapies such as disease-modifying anti-rheumatic drug treatment, which is very specific for the individual conditions like lupus Sjogren's or rheumatoid arthritis. High-impact activities should be avoided as a general rule, as they increase risk of acute subluxation and dislocation, and also increase the chronic pain. Activities like chiropractor adjustment and yoga should be performed, but with cautious to avoid iatrogenic injuries. Now let's discuss a very, very interesting topic about muscle activation syndrome and hypermobility. We know that the association among this condition and their prevalence in hypermobile EDS and HSD may be explained through consideration of the persistent chronic inflammation contributing to a disruption of the connective tissue. Aberrant mast cell activation has been shown to play a role in disrupting of connective tissue integrity through activity of its mediators, including histamine, tryptase, which affects multiple organ systems, resulting in a mast cell activation disorder. Mediators such as histamine and tryptase, which can cause widespread inflammation and multisystem involvement. In patients with hypermobile EDS and HSD, presence of mast cells can lead to increased severity of musculoskeletal pain, GI symptoms, skin rashes, and autonomic dysfunctions. Who are the most affected populations? Usually predominantly white females. And you get surprised, median age at symptom of onset is 9 years, and median age at diagnosis of muscle activation syndrome is 48 years, indicating a significant delay between symptom onset and diagnosis. There is emerging evidence suggesting potential genetic factors linking hypermobility syndrome and mast cell activation syndrome, particularly in the context of their overlapping symptoms and shared pathophysiological mechanisms involving chronic mast cell activation and mediator release. One study highlights that hypermobile EDS and hypermobile spectrum disorder are associated with mast cell, suggesting that certain variant of mast cell activation syndrome may drive some symptoms of EDS. This association is thought to be due to chronic inappropriate mast cell activation, which releases mediators like histamine, tryptase, and contributing disruption of the connective tissue integrity. Can we go to next slide? So what are those mast cells? We know that mast cells are part of our immune system, and we need those mast cells as a response to many outside factors like allergies, food, any environmental exposures. But these are really, we're talking about the aberrant mast cells that activation can produce inflammatory changes at the connective tissue level, leading to dysfunction of the multiple organ system. In peripheral nerves, mast cell can localize to the epineuron, peri, and endoneuron and release mediators which may activate nociceptor, producing symptoms like peripheral neuropathy and headaches. Mast cell mediation upregulates some of the cytokines that can lead to dysfunction of fibroblast proliferation in nasal and bronchial tissue, leading to rhinitis and sinusitis. Mast cell-induced TGF-beta upregulation and localization within the bronchial smooth muscle cells can cause modification of the matrix protein in a bronchial parenchyma, contributing to the tissue damage and asthma. Mast cell-induced TGF-beta upregulation in esophageal tissue can cause proliferation and smooth muscle contraction, contributing to esophagitis, which is similar to eosinophilic type. When mast cells are localized to connective tissue, they can cause microenvironment, contributing to rheumatology conditions such as rheumatoid arthritis and systemic lupus. Mast cell-induced change may contribute to a laxity within the blood vessels, causing pooling of the blood in extremities, contributing to a postural tachycardia syndrome, in which patients experience increase of their heart rate with standing, and this is very commonly found in association with hypermobile EDS. So let's focus on the right side here, how we make the diagnosis of mast cell activation syndrome. What are the clinical criteria? It's really 2 and more below clinical criteria we need to fulfill, and it can be with and without trigger. And this can be cutaneous manifestations such as flushing, pruritus, types like urticaria, angioedema, GI symptoms like vomiting, abdominal pain, diarrhea, sometimes constipation, respiratory symptoms such as laryngeal edema, shortness of breath, cough, stridor, wheezing, and even bronchospasm. Cardiovascular, loss of low blood pressure, abnormal heart rate, as well as syncope, such as also a loss of consciousness. Next slide. As we said, we need to have severe recurrent symptoms of the mast cell activation, at least in 2 organs of cutaneous, GI, pulmonary, and cardiovascular. In addition, laboratory criteria may help to identify if there is elevated tryptase or histamine level. And lastly, response to the mast cell mediator targeting therapy can be also part of the diagnostic criteria. So I really want to highlight post-COVID mast cell activation syndrome because we are seeing this more and more after COVID-19 infections. Briefly, usually the patients are females, and the severity of the illness really matters. More severe, there is more risk of getting the mast cell after COVID infection. Usually middle-aged individuals, mid-40s to 50s. Patients with pre-existing comorbidities, and this could be neuropsychiatric disorders, pulmonary disease, and high body mass index. Patients with persistent severe fatigue can be a risk factor. and elevated levels of interleukin, particularly interleukin-6 and other inflammatory markers, have been observed in patients with post-COVID conditions suggesting linked to mast cell activation syndrome. Personalized approach to managing mast cell activation syndrome is very important, focusing on symptom control, targeting specific mediators involving the mast cell activation. And this may include antihistamines, leukotriene antagonists, mast cell stabilizers, and even biologic therapy. First-line treatment, it's always antihistamines, histamine 1 and histamine 2, and really in a combination, because studies showed that if you try antihistamine only 1 or 2, it may not work as well as good as combination therapy. Then we oftentimes escalate treatment or add-on therapy with sodium cromolyn, which is more like a mast cell stabilizer agent. And this is particularly effective for those who have gastrointestinal symptoms, and it is typically administered orally. We can definitely use some medication such as montelukast. It is a leukotriene mediator, has a leukotriene mediator effect, and it provides additional symptom relief. And lastly, omalizumab, which is a relatively new drug, and it's mostly targeted therapy, anti-IgE monoclonal antibody, used in the cases where symptoms are not adequately controlled by other therapies. But these medications, we have to be careful, need to assess patient carefully, assess other risks, because they have potential side effects such as immunosuppression and the risk of infections. Nutrition support is important, given the high prevalence of GI symptoms and potential nutritional deficiencies in hypermobile patients. So really assessing micro and micronutrient deficiencies is important, and supplementing if it's necessary. And key component of the low histamine diet is really avoiding high histamine food, and those food can be aged cheese, fermented products, processed meats, alcohol, and certain fish like tuna. And also other food that has like a little less histamine, but those they can exclusively help with the liberation of the histamine. So those food can be such as some fruits like strawberry and bananas, tomato and chocolates. And I also want to briefly summarize small fiber neuropathy in hypermobile patients. Small fiber neuropathy involves damage to the small peripheral fibers, specifically thinly myelinated A delta fibers and unmyelinated C fibers, which are responsible for nociception, temperature sensation, and autonomic functions. And most of the time with small fiber neuropathy, we see the involvement of sensory and autonomic fibers. The study done demonstrating that 60% of hypermobile EDS patients had small fiber neuropathy, confirmed by reduced intraepidermal nerve fiber density on a skin biopsy. And this finding is consistent with the generalized distribution of the nerve fiber loss and various sensory disturbances reported in these patients. How we diagnose this? Usually we perform skin punch biopsy. It's oftentimes 2, sometimes can be 3 spots, usually in a thigh and ankle area. And we send specimens for special pathology assessment. And in this figure, we can see that in an A, basically, like we see normal skin layer with normal nerve fibers with normal densities, and in a B, definitely reduced intraepidermal nerve fiber densities.
So we're going to move right into Dr. Barbiere now. Thank you so much, Dr. Nino. We're going to try to save the questions for the end, just so we get through all this.
Sure.
Info. But wow, that was really interesting what you said about the onset of symptoms for MCAS and when they're actually diagnosed. We'll love to talk about that more maybe later or maybe some other time. But now, without further ado, Dr. Barbiere. Dr. Barbiere is going to be speaking about pain psychology and HSD and EDS. Okay.
Thank you for the introduction. Very honored to be here tonight. I'll get right into it. I'm Dr. Deborah Barbiere. I'm a health and pain psychologist for over 30 years. This is a specialty area of psychology that treats chronic illness and pain. I'm also licensed in Eastern medicine and acupuncture, which has been. Thank you for the introduction. Very honored to be here tonight. I'll get right into it. I'm Dr. Deborah Barbiere. I'm a health and pain psychologist for over 30 years. This is a specialty area of psychology that treats chronic illness and pain. I'm also licensed in Eastern medicine and acupuncture, which has been integrated into my practice. I've seen a lot over many years, and yet I've had a lot to learn about hypermobility and EDS, the most invaluable lessons coming from patients themselves. As we know, it can show up in so many different ways within the individual and over time, and there are no boxes. From my experience, the background and understanding is really necessary, but it's had to take a back seat to the flexibility and adaptability I've had to bring to each and every patient. Next, we may be aware of the zebra as the symbol for EDS, inspired by the popular medical phrase, when you hear hoofbeats, don't expect a zebra. Well, here we're talking about the zebra. We're called upon to expect the unexpected. These are many conditions that might, some of the many conditions that might show up in a therapist's office. And you can imagine how any taken in a vacuum can keep us from missing the big picture. We run the risk of only seeing one small piece of the puzzle. So it's not surprising. I've had patients going 40 years without a diagnosis, shuffled between doctors and surgeries, procedures, medications, therapies. They've really suffered in silence. They've been dismissed, made to doubt themselves and their experience every step of the way. We've heard it's in their head, it's growing pains, anxiety, and there's no framework within which to understand their experience. It's internalized, and there's so much self-blame and shame. And then maybe even the cause of their pain and suffering was a skill early on, like the flexibility that made them good at sports or gymnastics, and it became their identity. And this is confusing and very impactful. I'll say these are absolutely awe-inspiring individuals. They're warriors. They're inherently resilient. They've toughed it out. Society has required them to show up and mask up. And too often there's a backdrop of profound stress, trauma, disillusionment, and trust has been broken. And that's our starting point. There's a lot to overcome. So why psychology? HSD, DS affects the mind and the body. And this by no means suggests it's in anyone's head. It's very real. The reason we're here is that we know we need a multidisciplinary approach for a very complex, multifaceted condition. We can't divide ourselves into separate pieces and treat each in a vacuum. We're talking about an intricate web of symptoms. So how might it mask as psychological? That patient with POTS or dysautonomia, right, may show up with panic and anxiety, and they're on an autonomic roller coaster. If I miss the underlying organic causes, we might work on relaxation training or parasympathetic tone, only to find them rebounding back into stress mode or sympathetic, right? This is not a failure of the patient, rather perhaps a failure of the approach. It's not uncommon to be ping-ponging, as you've heard earlier, between sympathetic and parasympathetic, or our accelerator and brakes, we say sometimes respectively, or have both activated at the same time, feeling both relaxed and jittery simultaneously. So we may not be able to use conventional approaches and or expect conventional results. Another example is a patient who was referred to me for stress management to treat unmitigated incontinence, which her doctors concluded was emotional. And we proceeded to treat her stress, but with some probing, it turned out she had hypermobility signs, as did her mother and brother. And her treatment team is finally investigating this, and she had to bring it to their attention. We saw earlier the multitude of comorbidities where mind and body converge. These are all many of which are within the purview of the psychologist, the attentional issues, the neurodivergence, the mood and sleep disorders, and so on. Even broader, though, beyond mind and body, this is a biopsychosocial syndrome. And what that means is there's an interplay between biological factors such as genetics, especially here, inflammation, sleep, psychological factors as depression, anxiety, trauma, and social factors as the impact on relationships, financial stress, bias and discrimination, medical and insurance accessibility, which in combination are observed to predispose and precipitate illness and pain, as well as perpetuate or protect one from flares or exacerbations. On to slide 5. So the psychologist helps to manage adverse biopsychosocial influences. Depression or fear, for instance, can have debilitating consequences if someone is staying in bed and immobile, posing risk for injury, weakening the body, and certainly can impact medical outcome. Social isolation can be a barrier. We all need healthy relationships. Social medicine is a real thing. In the presence of others, our brains and bodies release good hormones to improve health and mood, like oxytocin, serotonin, dopamine, endorphins. Accessibility to medical care, information, and advocacy affects outcomes. And living with chronic pain and illness puts tremendous strain on the central nervous system. We're always thinking about restoring the nervous system to safety as much as possible, filling safety buckets and reducing threat buckets as much as possible. So persistent sense of danger over time leads to brain changes that impacts our ability to modulate pain, amongst other things, which we'll talk about in a minute. Those comorbidities, as we mentioned, can be treatment barriers and further debilitating and need attention. We want patients to be informed about their diagnosis. Knowledge mitigates fear, facilitates communication, also improves outcomes. We want to empower patients to advocate for themselves while surrounding themselves with support, strong treatment teams and allies, helping them to build a life worth living and moving from surviving to thriving. And let's look a little bit at the pain neuroscience. A primary focus of the psychologist treating the pain is the brain and central nervous system. The brain shapes our experience of pain and becomes reshaped by chronic pain. So going a little bit deeper into this, how pain works, this is a very real way the brain and the body are connected. Pain is 100% produced in the brain. We don't need the body to have pain. As we see in phantom limb syndrome, as many as 90% of people who have an amputation will experience phantom pain in part of the body that's no longer there. And this can resolve for many people, or it can become chronic or permanent. So we have body tissues. The skin, deep tissue, visceral organs contain nociceptive sensors that are our threat detectors. These fibers send danger messages, not pain messages, to the brain. This is our harm alarm system, a protective mechanism necessary for survival, and it's what helps us to move away from danger. Also, pain is a diffuse neurological process, sharing real estate with regions of the brain involving thoughts, emotions, memories, attention, all of which play a part in how our brain organizes itself and responds to these incoming signals. In chronic pain, however, this natural survival mechanism goes haywire. Those danger messages are generated internally over and over again, but it's not like that hot flame that we can move away from. We can't get away from it. It's coming from within. It's like Groundhog Day. And over time, this can rewire and reshape the central nervous system in fundamental ways. The nerves can stay electrified. It's almost like a home alarm system set to the most sensitive setting where it's detecting every movement. Pain pathways become practiced, transmitting faster and louder. And if there's any PTSD, early trauma, we can have the brain pre-wired this way, predisposing us for heightened pain sensations. Studies even show over time growth in the amygdala, the fear center of the brain, keeping us in fight or flight, while other areas of the brain responsible for pain modulation shrink. Scans show alterations in gray matter affecting information processing, cognition, memory, making something like brain fog even more debilitating. And neurochemically, we have altered immune, endocrine, hormonal function, and inflammatory factors with chronic stress and pain. So just going to the diagram to review, to illustrate, we have the sensation of that hot flame, sending a signal to the brain. The brain's interpreting the signal, danger, allowing us to move away from harm. This is our pain processing computer. With persistent pain, the system can become super sensitive or sensitized. And looking at pain as a diffuse neurological process. These are parts of the brain that can come online to interpret incoming signals. Maybe there's trauma around fire, eliciting intense memories and emotions, or the person that's burning their finger is a professional pianist, which also comes with a lot of charged associations and feelings. And these are factors to make pain louder. Threat perception is different for each individual and will shape their unique pain experience. And looking at benefits here, you can start to see with all of this how changing thoughts and feelings, working through trauma, resourcing patients to improve coping can alter how our brain processes pain. And the good news is neuroplasticity. This is known to be somewhat malleable through regular practice of cognitive behavioral skills, somatic and relaxation strategies, working alongside specialized therapists. We can lower the volume on pain and other symptoms. We can stall or even reverse some of these neurological and neurochemical changes. We can maximize treatment efficacy. Stress, expectations, thoughts, emotions are known to play a role in the effectiveness of pain treatment. For instance, studies show negative expectations can completely reverse the analgesic or pain relieving effects of a clinical dose of opioid. So we have synergistic effects with other pain treatments contributing to improved pain, symptom, and stress management. Moving on to modalities, to create mind-body changes, we have to combine top-down and bottom-up modalities. And what does that mean? We need to work on the level of the body to affect change in the mind, and we have to work in the mind, on the level of the mind to affect change in the body. Many traditional psychological therapies are very top-heavy, promoting understanding and insight, which is all great, but the key is embodied change. With chronic illness and pain, it's very common to become detached from the body, which has not been a safe place, and body and mind become very compartmentalized. So it's really important that the work we're doing reintegrate and restore pathways of communication between the body and mind. Some of the tools that have proven efficacy, cognitive behavioral therapy, acceptance and commitment therapy. These are empirically driven approaches, a lot of research behind them. It's a large part of the work. They are top-down therapies that examine how we relate to symptoms. Habits of thinking impact the brain and the body, either positively or negatively, reverberating safety or danger. Cognitive behavioral work involves identifying unhelpful thought patterns and building healthy narratives. In ACT, we're also helping patients to thrive, living their best life through exploration of values and reclaiming meaning and purpose, even if life doesn't look the way they expected it to. We have mindfulness and somatic processing, very important, mind-body awareness, which is a conduit to change. Entering the observation tower of our mind or bringing the prefrontal cortex online, however you want to see it, it allows for some distance and choice in how we relate to experiences. If we can imagine the sky as metaphor, right, as a container for sun, birds, stars, as well as clouds and changing weather patterns, all holding space for all of it. Bringing awareness to the body can help prevent injury, letting you know what your body needs. Do you need movement or stillness? Do you need a walk or a phone call or music or writing? Patients often find even doing exercises in their therapy, physical therapy works better when they're present in their body. Body-centered relaxation strategies work mainly bottom up to turn down that harm alarm. Something like progressive muscle relaxation, for example, can reduce guarding, protective postures that increase injury and pain. Movement, we know, can often come to signal pain, so we can end up with a fear of movement or kinesiophobia. Techniques like gradual exposure or systematic desensitization, even hypnosis can reduce fear and help to build pain and movement tolerance within safe parameters. Biofeedback uses electrodes to monitor the nervous system. With computer feedback, patients can observe real-time changes in muscle tension, respiration, heart rate, sweat gland activity, vascular function, brain waves, while practicing techniques. And this really helps to perfect those techniques and facilitates learning. The proof that it's working really helps patients gain confidence in skills. Knowing that breathing can affect change in their entire nervous system is really compelling, and encourages folks to use those tools. This is especially useful with dysautonomia, where patients can very specifically learn to steer their nervous system in a specific direction, whether activating sympathetic or parasympathetic activity, depending on the state of their nervous system. Safe and sound protocol is a form of neurofeedback. It targets the vagal system. This was developed by Stephen Porges, a neuroscientist and trauma specialist. And this uses filtered music to entrain safety frequencies in the nervous system. And I will use psychological applications of acupuncture and Eastern modalities, combining in an acupuncture session, for instance, we'll use guided imagery, meditation, somatic processing to help reset and remodel the nervous system. And continuing on with other modalities, there's so many of them, so many more, and I'm just trying to touch on the key tools of the psychologist. Sleep training is very important. Journaling and logs, tracking pain and emotional and physical triggers, pain and symptom management plans, having a plan, plans to use preventatively and in acute flares, having those at your fingertips, activity pacing, avoiding those boom and bust patterns, not overdoing it. It's about consistency more than quantity. I can't stress enough the importance of involving family, loved ones. I work a lot with couples And I also want to just add a piece here about intergenerational trauma, which is just something that I've observed over and over again um, with hypermobility and EDS. We have generations of undiagnosed parents rarely raising undiagnosed children who are raising their own children before anyone is ever accurately diagnosed and treated. And this raises a lot of issues and often needs to be addressed in family work. And overcoming trauma. We support groups, incredibly important. I'll put in a plug for Manhattan Pain Medicine. We have a pain support group the last Wednesday of every month. And also look out for our empowered relief groups, which is a 2-hour pain education program. It's got a lot of research behind it. We've fortunately been licensed by Stanford to offer this to our patients. So patients can certainly contact us about that. And I'll end there.
Thank you so much, Dr. Barbiere. Always wonderful to hear about all of the modalities and different treatments that you offer, because it really helps so many people. So I'm going to move into the final lecture. I know everyone's still hanging on there. It's a Tuesday evening and we're getting deep into a lot of topics regarding EDS and HSD, but I hope you all are, learning something or at least taking away something from it. So I'm going to move now into physical therapy and exercise specific considerations for people with EDS and HSD. Okay. Alrighty. So as I said in the beginning, my name is Melanie Carminati. I'm a doctor of physical therapy. I'm also a Pilates practitioner and educator. I've worked as adjunct faculty at Fordham University, teaching anatomy and kinesiology for the Fordham Alvin Dance program. And I'm the owner of Inspira Physical Therapy and Pilates in Park Slope, Brooklyn. I was a dancer. And when I got my Pilates certification and then became a physical therapist, I was given the people who had hypermobility and EDS, and I remembered 2 of my first patients, and it really demonstrates the spectrum of and the variety of presentation. One patient, unfortunately, was primarily wheelchair bound, and the other was on the other side of the spectrum, where she was preparing to or was more like pre-professional dancer, ballerina. So it was an interesting spectrum to see, and I want to emphasize that it is a spectrum. And as Dr. Siefferman, one of his earlier slides, he demonstrated that spider map from the EDS Society. Everyone's presentation is different. There are, of course, people who are asymptomatic with hypermobility, but we're specifically speaking about the symptomatic presentation of HSD. So when I think of HSD and EDS as a physical therapist, as a movement practitioner, I think of it as an umbrella. And so under that umbrella terminology of HSD and EDS, there are all these other comorbidities, which the other physicians have already mentioned this evening. You have MCAS, you have dysautonomia, POTS, gastromotility issues, orthostatic intolerance, endometriosis, pelvic organ prolapse, all of these other things you can see listed there. And I've highlighted the ones that, for me as a physical therapist, as a movement practitioner, I am thinking, okay, if I'm going to be moving this person, if I want to guide this person through exercise, what do I need to be really considering here in terms of the comorbidities? Definitely dysautonomia, POTS, if that's present. Another type of orthostatic intolerance, if there's pelvic organ prolapse, if there's CCI, if they have frequent joint subluxations, chronic pain, fatigue, sleep dysfunctions, ADHD, autism, all of these things I am considering because it's going to impact how I develop a very personalized and individualized therapeutic exercise program and overall treatment plan for this patient. So we've mentioned dysautonomia a bit, but I just wanted to put this in there. Dr. Siefferman did cover this again, that we're talking about a dysregulation in the autonomic nervous system. Those are the things that are happening involuntarily in your body, such as heart rate and blood pressure, digestion, dilation, etc. And so when we are seeing patients in our office for physical therapy and they have some type of dysautonomia, we are always doing vital monitoring. So we're monitoring heart rate, blood pressure. We're also just doing visual assessment as well, because many times symptoms for dysautonomia could just be feeling very fatigued or just feeling sick, or feeling, a change in body temperature, extreme heat, sweating all of a sudden. So when we are working with patients who have dysautonomia, we're monitoring the vitals and we're definitely making sure that we're visually assessing as well. I just want to mention for any of the physical therapists out there, or other movement practitioners who want to learn more about this, these are some of the methods that are old and some evolving, and then just some other resources I wanted to just make and mention for everyone. Myself, I guess 12 years ago plus, when I first started treating this patient population, the Living Life to the Fullest by Kevin Muldowney was one of the first and only books that I had available to myself. And then most recently, Taming the Zebra has come out. There are many physical therapists, or not many, but there's a few physical therapists who have many resources, like Leslie Russick for physical therapists, just to learn more. EDS Society is wonderful as well. So when it comes to the research, what is strongly represented and proven and evidence-based is the fact that therapeutic exercise is extremely helpful for people with EDS and HSD. There is more research that's needed to be done, specifically targeting fascia and the central nervous system. Now, fascia is connective tissue that covers our entire body from head to toe. The other presenters have mentioned this, but this connective tissue contains proprioceptors and nociceptors, and it's important to consider that there is a need to provide more feedback for proprioception in individuals with EDS and HSD when you are trying to implement exercise. So what will that look like? That will look like using spring resistance, different kinds of loads, weights, therabands, different props, but just giving some more feedback into the body to help utilize that fascial system, utilize the fascial slings to facilitate effective and safe exercise. Now, I think a common misconception, and I'll mention this in a later slide where I talk more about Pilates specific exercise, is that you always want to do very light resistance or light springs. And that's not actually the case. You need to kind of titrate and find that proper amount of feedback that that person's body needs, what that person's fascial system, musculoskeletal system needs in order to properly stabilize in their joints and activating those stabilizing muscles. So for myself and my team at Inspira, we have a multi-system approach that we use, and we start a lot with the nervous system. So craniosacral therapy is heavily used, vagus nerve manual therapy, visceral manipulation. All of these techniques are very light, gentle, hands-on techniques, and it really requires the practitioner to have hands that can listen and can feel the tissue. With that kind of intention of listening to the tissue, you can feel what and how much that person might need, but it gives you feedback additionally in regards to the quality of the tissue, and the patient will also give you verbal feedback while you're doing these treatments. We move into lymphatic manual therapy because commonly there's a need for lymphatic drainage. Radio frequency treatment, we use wind back to car therapy in our office quite a bit. It's amazing for pain relief, as well as proprioceptive input can be used for edema. We do manual therapy for musculoskeletal concerns like muscle spasms, other myofascial techniques. We do use kinesiotape a ton. This is another way to provide amazing feedback and joint stability for those hypermobile or HEDS people. Depending on how you use the tape, could be just for joint stability, could be for muscle facilitation or inhibition. And then when it comes to neuromuscular reeducation, for the movement portion, we are using motor control principles, Pilates exercise progressions, and a lot of proprioceptive guided input from the different methods that I mentioned, like weights or therabands or different props. Now, if someone has POTS and dysautonomia, we will consider integrating a cardio training program with them. And also, if someone has POTS and dysautonomia or dysautonomia, we will always be starting in supine. I'm going to mention, I think in the next slide, maybe not, in an upcoming slide, that starting in supine is the easiest for people with POTS and dysautonomia for the nervous system. It is a position of rest, and it does allow the nervous system to reset. So we want to be facilitating that while we're doing movement re-education. So physical impairments to consider with exercise prescription. So say that you're with a patient, new patient who, or client, depending on what your scope of practice is, if you're a movement practitioner, and you want to implement movement and exercises with them. Things to consider. Where are they the most hypermobile? Where do they have the excessive movement at their joints? Commonly it is diffused, but more often than not, they have one joint that is more problematic than the other. They will have challenges with completing exercise without injury. So there may be some past trauma related to movement. So just know that they might be coming from a place of fear when they're reintroducing movement, and to always try to facilitate a positive movement experience for them. Pain often is multi-regional, dizziness, fatigue, weakness, fainting risk, difficulty coordinating movements. This is related to multiple things, but heavily to that proprioceptive, or that need for more proprioceptive feedback, decreased proprioception, gastric bloating. A few notes about POTS. So here's the slide that I was mentioning before. So supine exercises are the easiest for people with POTS to complete. The autonomic nervous system also likes to use the supine position as a nervous system reset position. When I work with people who have severe cases of dysautonomia and POTS, I do always recommend that they're using the supine break. Supine, for those who don't know, means laying on your back. And even better if you can get your legs elevated above heart level. If you're able to implement supine breaks in your day every 60 to 90 minutes for about 15 minutes, this is going to help restabilize your nervous system. This goes back to some old cardio training and specific POTS research. It's something that I do recommend to my patients when they are having the most problems with dysautonomia. In terms of physical exercise, standing and sits to stands are going to be the most challenging and really should be incorporated with caution. It's pretty rare that I'm going to implement any standing exercises with someone who has dysautonomia POTS in the first phase of care until I have done enough supine and other position exercises to give their nervous system time to orient to those orientations to gravity and then build up the strength and stability they need. Other recommendations: hydration and electrolytes are really crucial, sleep, stress management, weather. If some of you who are joining us now have POTS or different forms of dysautonomia, you know the summer in New York is really hard and can commonly cause a flare in POTS symptoms. Also recommended, because of the frequency of fainting, to be wearing a bracelet, or just to be walking with friends who know that if you faint, they know what to do and whether or not you want them to send you to the ER or not. So physical therapy, my recommendations are that it has to be multi-system approach. As you all have heard from the other presenters, we are not just dealing with a musculoskeletal condition. This is multiple systems involved, and we have to consider that and consider all the risks when we're prescribing exercise. At Inspira, we use a 16-week program or 4 phases of care. It's just something that we did like a little troubleshooting to figure out internally for what would work best for our patients. Tried 8 weeks, tried 12, 16 weeks seems to be like the sweet spot for our patients in really progressing them to a place of more independence and care, and then really needing us or just coming in as an on-needed basis. As I mentioned, it's recommended to do nervous system work first. This can include craniosacral therapy, vagus nerve work, other manual therapy techniques, radiofrequency. Exercise recommendations. We want to be focusing on stabilizing the joints, strengthening those stabilizing muscles around the joints and building strength. Exercise progressions and movement reeducation will happen at a slower pace due to the aforementioned structural differences. So just be mindful and set yourself up for that, just to know it's going to go at a slower pace. I already mentioned supine exercises are best. And for the Pilates people who are joining us today, reformer work, that's my timer, reformer work and supine mat work is ideal to initiate the exercises. Pilates is amazing. There has been some data and articles mentioning the importance and the benefit of Pilates because it really allows the hypermobile group, the people with hypermobility, to do so much exercise in safe positions and also give them that feedback that they need from the springs, from the ropes. So Pilates is really wonderful, and we do use that quite a bit. In terms of where you want to start first, we always start with core and lumbopelvic stability. We need to have that under control before we're working with the other joints. We commonly will be doing this in addition to other symptomatic body regions. Pilates specific recommendations: moderate spring load is typically better than light. Start supine, use your props, use the supports to facilitate proprioceptive feedback. Re-education of posture is crucial and may require different cueing to facilitate properly. So going along the lines of one of the comorbidities of ADHD and autism, knowing how to cue the person in front of you. Some cues work better for certain people, and I know we all have experienced this. We probably have that one cue that works for a majority of people, and then we meet that one patient or client and it's just not working. Well, then we have to get creative, use visual imagery. I use mirrors a lot in our office. Sometimes I will video record my patients doing the exercises so they can go back and watch. Yes. Focus on strength and stability around the joints, and closed chain and pseudo closed chain exercises will be the easiest and safest. And then open chain, meaning without the resistance, is going to be the most challenging to coordinate. I do run a Pilates for hypermobility workshop with my team every May. So stay posted for that. Birthing positions. I just want to mention some pelvic floor stuff. I did just present recently to a birth doula collective, and there was a lot of considerations to talk about, and I wish we would have had time for a lab to really get into it, but just a few quick things. If you're a movement practitioner or someone working with the pregnant population, avoiding hanging positions, really encouraging them to be bracing and get that feedback from the wall or a sturdy surface, using the breath, using the posture, avoiding positions that aggravate the hypermobile joint position, and then using other supports and props. Last thing, just in regards to the pelvic floor, because we do treat pelvic floor conditions in our office as well, specific to EDS and HSD, we're always thinking, okay, is there an existing pelvic organ prolapse of different type? Do they have a history of pelvic pain? Is there a history of vulvar fissures? You will have skin sensitivity commonly if you have EDS and HSD. And then where are their joint dislocations? Do they have recurrent hip dislocations? Is that referring into the pelvic floor? Yes. So just some references. And then the exciting moment has come where we are going to do a case discussion. So all four of us are going to discuss a case. I'm going to just go through it briefly and then talk about the PT stuff, because I believe how the collaboration happened between the four of us was that the patient first came to me, and then I referred to my team here at Manhattan Pain Medicine for further care. So case study, here we go. So patient history, and some of this will sound familiar for those who have been with us for the whole presentation. So patient is 33-year-old cisgender female, assigned female at birth, with complaints of occasional pinched nerve pain. They were referring to that in their neck. Tight feeling, hip impingement pain that is severe and occasional. Preferred pronouns she and her. Also, it's not listed there, but she had said that when they would have that hip impingement pain, the pain would be so severe sometimes they would pass out. So this hip pain is certainly severe. Patient works as a movement practitioner, dance educator, collegiate level professor. Main mode of transportation is the bicycle. They have severe pelvic pain associated with the onset of menstrual cycle. Patient reported suspected prolapse that she felt this past summer while teaching at a dance intensive, palpated a bulge. However, this since has resolved and is not a chief complaint. Patient also reported a history of intense allergic reactions with no known cause, could be so severe that her eyes swelled shut. Patient reports she's often fatigued and feels lightheaded, has fainted sometimes. Patient is taking medications as needed for ADHD, mentioned suspected autism, social history. Patient lives alone but nearby her partner, has a good support system. Patient presented to PT concerned that she has EDS and is worried if she should stop exercising and concerned about her career. So what I found with this patient, they had bilateral muscle spasms in their scalenes and upper trapezius. They presented with the typical bite and scale signs. Posture was well controlled. This person is a mover and has found themselves into a career and a movement practice that has really helped to stabilize their joints and provided them with more muscular strength and feedback to give them a high level of activity, with palpation, left hip moderate tenderness through hip flexor region and joint space. So we did about 16 weeks of care. We did a lot of craniosacral therapy in the beginning and vagus nerve manual therapy. Patient reported relief after this in regards to fatigue and brain fog and discomfort level. We did a lot of Pilates-based neuromuscular re-ed, focusing on educating them out of compensatory patterns. For those who are with us right now, you likely have seen the hypermobile patient and client population. They find very inventive ways to use muscle groups that aren't supposed to be the main driver for the motion at the joint. So really re-educating that. Discovery of neutral knee extension. We use kinesio tape a lot. Other osteopathic techniques, such as for the facet joints in the cervical spine, and then education on POTS and provided recommendations for compression socks and electrolytes. So now I referred this patient to Dr. Siefferman for pain management, MCAS, workup with Dr. Nino, and advised the patient to continue exercising. As some of you also know, many times when a hypermobile person gets injured, and if they are very active prior, and then they stop for a long, long period of time out of fear of re-injury, a lot of their muscular strength and neuromuscular motor pathways kind of fall to the wayside, and that was really helping them. So I did encourage her to continue exercise with modifications, and then we discussed the suspected endometriosis